Um, I think about it a lot. People don't do it anymore, and it just drives me insane. I don't understand how you cannot clean somebody's mouth with that. Okay? People who aren't eating and drinking, and we let them lay there in the bed for 5 to 7 days with no oral care whatsoever. Would you want to be done that way? I can't stand it. I don't brush my teeth 3, 4, 5 times a day.
What's all that bacteria does to your lungs?
Goes to your heart too. You know? So I will stress mouth care in a lot of things. And you know what? Who can do mouth care? Anyone. Anyone can do mouth care. You can delegate it. Okay? Anyone can do mouth care. And you're never too good to do mouth care. So our our prescription, we're going to look at barbiturates to decrease the metabolism, vasopressors for systolic blood pressure, and anticonvulsants. No, I'm not listing any meds on here. The meds that I give you and I talk about will be the meds that you will be responsible for. Okay? E, edema management. Mannitol. You may know what mannitol is? It is an osmotic diuretic used to treat cerebral edema that pulls the water out of the extracellular space of the edematous brain tissue. Okay? Mannitol. You administer it through an IV. You can put it through tubing or you can give it IV push. You have to draw it up with a filter needle. Important. Filter needle, not just a regular needle. Because you have to eliminate any microscopic crystals that are in mannitol. Okay. Non-state, M-A-N-N-I-T-O-L. It's fine. Actually, it's not my bad. It's Miss Chandler's bad. She didn't spell it right. I just had to. When they're on mannitol, you want to monitor their intake and output. That would be strict as nose. Very, very strict as nose. So if they're sedated, your input's mainly going to be IV fluid, right? So you need to monitor your IV fluid you're putting in, and you need to monitor what's coming out. These people are probably going to have a fully catheter because you're not going to be wanting to turn somebody with increased intracranial pressure all the time, right? But it is important to monitor your eyes and nose. You need to watch for severe dehydration in these patients because mannitol pulls a lot of fluid. You want to watch for acute renal failure. Weakness, edema, and when they're on mannitol, you're going to check their serum electrolytes every 6 hours. So, Your serum electrolytes, you're going to check them every 6. So what electrolytes would we be looking for? What's your normal range of sodium?
136 to 145.
I'll give it a normal range. Give me another one.
Potassium.
Normal potassium.
335.
What else? What's your normal calcium level?
110 to 11.
9 to 10.5.
What else?
Do you monitor magnesium?
What's your normal magnesium level? Look it up. You got a lab sheet. don't you? Why is potassium and magnesium important?
To work on the
Say it
heart.
loud. Your heart. Can cause irregular rhythm. Do we need to add any more irregularity to this person? No. What does potassium cause? Come on. Pull it out from the heart.
Elevated T.
Hyperkalemia. Elevated T's. You want them on a monitor? What can magnesium do? Come on. I'm looking for what? Magnesium. Come on, guys. Talk to me. Can also come under irregular rhythms. Okay. So ICP monitoring. We need to monitor all the spaces of the brain, right? 25 to 10. Common diagnostic testing, MRIs and CTs is the number one. That's neuroimaging. Skull, X-ray, skull radiographic and X-ray. An ECG. What's an ECG? Related to ECG. Brain biopsy. What? What's that? Lumbar puncture. Very rarely, but only if there's not. If it has to be. But your book does list it as but I would not.
It says on here that it just goes into arrhythmia and heart palpitations.
It can grow in two times. That's first that's the point. Magnesium is a we don't think of it as like a critical electrolyte, but it is. Magnesium is a critical electrolyte. Potassium, chloride, sodium, calcium. I would know every one of those lab values. So when we manage somebody with ICP, there are many, many treatment strategies. And it all depends on the underlying condition. Our goal is to prevent secondary injury to the brain. Our goal is to improve and maintain cerebral perfusion. So we want to reduce cerebral edema, and we want to reduce the ICP. These together help reduce the chances of any herniation. Okay? Brain tumors can cause ICP, and I can't tell you how lately that's been on my mind. I've had 2 people close to me that have been diagnosed with brain tumors lately. One was a former student who graduated about a year ago who ended up with a brain tumor. And then my cousin's husband, he's in his 40s, ended up with a brain tumor. So we're seeing a lot more, or maybe it's something just around me, I don't know. But I'm seeing more and more brain tumors in people's in their 40s, They can have these 50s. Brain tumors, they will cause seizures. That is probably the first sign that they even have that they have one. They'll start to have seizures. The brain accommodates for the little bit of growth of the mass inside there. How we talked about at the beginning with fluids, the mass starts small, so it compensates for that. It allows for that until it gets too large, and then normally the first sign that they will see will be a seizure. So, anti-epileptic medication may be ordered for these people so they don't go into seizures. Glasgow Coma Scale, here it is. Even though we went over, I'm going to beat this into you. It's very important. Eyes open spontaneously, the beautiful word. Speech and worry, pain. And you can only choose one answer. Only one. Okay. And the table in your book is 38.7, not 38. Interventions to lower intracranial pressure. Positioning. Number 1. Activity management. They don't need a lot of activity. Airway management. Hyperventilation and bowel management. We did not want them straining for any reason whatsoever. So you would see them probably on a cold raise or some type of medication that would help them feel better than I We need to treat hypotension quickly. With autoregulation, the blood flow to the brain decreases. When the MAP decreases, the ICP increases. And ICP increases. Craniotomies. The main thing to watch for with them are signs and symptoms of hypernatremia. You want to assess their sodium levels. Brain death criteria. Determining brain death, the latest is 2010 from the American Academy of Neurology. That's when it was last updated, okay, because there's no need to change it every. So when they go into a coma of a known cause that is established by their history, their clinical examination, their laboratory testing, or neuroimaging, coma of a known cause from any of those established by their history, clinical examination, laboratory test, or neuroimaging. Okay? Normal or near normal core temperature, higher than 96.8. Normal systolic blood pressure, higher than or equal to 100. And at least one neurological examination. In the United States, though, we do require two neurological examinations to determine brain death. All right, before we go on to seizures, I'm going to stress a couple of things to you here. And as you can see, it's coming from your gut, right? Traumatic brain injury is damage to the brain from any external mechanical force, right? A blow to the head is considered what kind?
Direct.
If a force is applied to another body that affects the brain, that is known as
Indirect.
What is an open brain injury?
Where the skull's fractured and the brain is punctured.
Concussion?
Loss of consciousness for less than 30 minutes.
It's not. Right. Yep. What would you want to watch for in somebody who's had a concussion?
Their level of consciousness.
Headache, impaired cognition, dizziness. Those are the things you want to monitor because those can occur for a while afterwards, after they have a concussion. Okay. They can have vertigo. What's vertigo? Okay. Chronic traumatic encephalopathy is a degenerative brain disease, okay, that can cause ICP. It occurs mostly with our military, our athletes, and others who experience repeated trauma. Okay. What's that called? Chronic traumatic encephalopathy. You hear a lot of it in pro football. They just didn't use that word on TV, but yes, I guarantee
OJ tried to use that.
Ah.
Yeah.
Poor old OJ.
Yeah.
You said pro football, military.
Wow.
You said pro football, military.
Your veterans, your military veterans from being in the military and receiving trauma to the head. Your athletes and anyone who experiences repetitive trauma to the head. Okay? I think how many football players get a concussion this week and then go out and play next week and get another one? How many go out and then a month later they get another one? You know what I mean? That's why they said that with him, I think he had how many when they said that? I mean, he had several.
They talk about pro wrestlers.
Probably. But it happened in high school wrestlers. It can happen in high school football. I just use pro football as an example because I'm sure everybody has heard on the news about it, you know. So those are considered secondary brain injury. That's considered a secondary brain injury because it has occurred repeatedly. Okay. If they get hypotension, it can be related to what? Shock. Shock. Hypotension related to shock. Hypoxia, because the blood is not carrying enough oxygen to the brain. Right? This can be reduced perfusion related to blood clots. Remember, they can become hypoxia with blood clots, the two letters, many things like that. You want to monitor them for respiratory failure, asphyxiation. You always want to monitor their airway. What is the normal level of ICP in the brain? A sustained ICP greater than 20 is detrimental. Remember? Detrimental. Subdural hematoma results from the venous bleeding into the space in the dura mater of the brain, right? See this a lot with what? Yeah. Go to peas for me. Yeah. Brain injury is the 5th leading cause of death in older adults. Kind of a big number. Ages 65 to 75 have the second highest incidence of brain injury of all age groups. Ages 65 to 75 have the second highest incidence of brain injuries of all age groups. Falls usually cause subdural hematomas. like that your book says that no two brain injuries will ever be alike. They'll never be alike. Anybody who has a brain injury, you need to assess for increased ICP, hypotension, hypoxemia, increased partial pressures, .4 in your book is a table about your mild brain injuries, your moderate, and your severe. Remember that if they have a brain injury, you don't know if the spinal cord is involved, so they will be placed in a cervical collar and on a board and treated with it. These are people you don't just go jerk out of a car unless the car's on fire, and you know what I mean? Like, unless you have to at that point. These people need to remain stable until somebody with a board and a collar can get there. Okay? Some other signs and symptoms of brain injury, they can look dazed or stunned. Again, back over the headache, the nausea, vomiting. They can have gait imbalance problems with their gait. Dizziness, fatigue, sensitivity to light, and sensitivity to noise. Migraine headaches, that falls in there, and I like to use that because people can just have a sensitivity to light and to noise. Some people can experience amnesia from the injury. One of my favorite. Just a moment. Cushing's triad is what? It's a late sign. What is the classifications of Cushing's triad? Increased blood pressure, decreased pulse, decreased respiration. The most important thing to assess with a brain injury is LOC. LOC, level of consciousness. Mannitol. What is it? What does it do?
Cools water.
How do you give it?
IV first. With a filter.
Yes. Yes. Monitor what?
Serum electrolytes.
Serum electrolytes would be what? No, you're right, right? Our main nursing outcome for anybody with a brain injury is they will not experience long-term decreased cognition or sensory perception or mobility deficits. our outcome is that we do not want them to experience long-term decreased ability of cognition, sensory perception, or mobility. We want them to return to normal, right? That is our outcome. These people take a long time to recover. I'll stress that again. Many require rehabilitation for months after the injury. We talked a little bit about brain tumors. Not so much going to go into that. We've already covered on the cancer part of it, as you said. We can't cover all the cancers in the body, but we did talk about it. Like I said, I've seen a lot of it lately. But the main thing is to make it increase pressure. Okay? And the first thing that they'll normally experience is a seizure. Of course, they're going to be on chemotherapy, surgical procedures, they'll do operations. Yes.
When you were talking about the long term, the reason I do all this is I had a friend who, I don't know the technical details, but more or less like fell off the balcony, he was drunk, he was dead, and somehow he wasn't cardiac arrest. They got him back, but saw him the next day in the hospital, and he like, like a vegetative state, couldn't do anything, all this other thing. The very next day, he was like himself, but he had like the memory of a goldfish. And then it took him like 3 years and he finally got it. It was just like a progressive thing. He slowly got his memory back. But it took like years.
It's not something short term, it takes a long time. Your squash takes a long time to heal. Okay? Alright, so now we're going to go to the seizures. It is an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain that result in a level of consciousness. Motor or sensory ability or behavior, right? How many have seen somebody have a seizure? It's not fair. It's not uncommon to you all, right? There are many types of seizures. There are generalized, tonic-clonic, myoclonic, atonic, partial, partial complex, simple partial, and idiopathic. Many types of seizures, right? They may be caused by traumatic brain injury, metabolic disorders, electrolytes, alcohol withdrawal, heart disease, high fevers, strokes, and substance abuse. Seizure precautions. Always, if you have somebody who has a history of seizures, not that they need it at that moment, but you need to have it in the room. You need to have oxygen. You need to have suctioning equipment. You need to have airway equipment readily available. They have to have IV access. Have to, and it needs to work. Side rails up. At CAMC, they will have you to pad the side rails with blankets and tape blankets onto the side rails so when they do have a seizure, they do not hit themselves on the side rails in the bed. Do you hold them down?
No.
Do you stick anything in their mouth?
No.
No. We try to protect them as much as we can by providing that, but we cannot do the things that I just mentioned. You do not hold them down. What's your first drug of choice when somebody has a seizure? Ativan. Seizures affect all ages, don't they? Seizure management will depend upon the type of seizure that they're having. Okay. We want to observe, and you need to document how long they have that seizure for. Right. Not that you can provide any intervention at the time other than Ativan. Okay, if they're not wailing, and you can get to the IV site. Okay. Patient safety is a big issue. They can bite their tongues. They can hurt themselves. Okay. Sideline position, if possible. If possible, you put them in a sideline position so their tongue doesn't go back, right? Okay. No restraints, no holding them down. You holding them down is a restraint. Never force anything into their mouth. Tongue blade, anything, nothing. Okay. A VNS is tunneled under the skin and connects to the vagus nerve. That's the vagus nerve stimulation. Complications after surgery are hoarseness. That is the most common. Dysphagia, neck pain, and dyspnea. All right, I'm going to give you guys 7. Come back at 10. About 10 days.